everyone. My name is Kristen Goulden, and I will be presenting over my DMP scholarly project, which was an evaluation of a quality improvement project for implanting cardiac loop recorders. The committee members listed here were instrumental in my ability to complete this project. So Dr. Berger was my faculty chair who helped me each step of the way. Dr. Pavlovchik was helpful in primarily helping with the IRB proposal and approval. And then Mark Pauls was the Maryville statistician that helped in all of the statistical analyses and proper sampling and data collection ideas. And Tracy Garner was my facilities charge nurse and the interim team lead who helped with the facility related aspects of this project. So first I wanted to discuss what a loop recorder actually is. So for those of you who are unfamiliar, it is a small implantable device that sits right under the skin. It just sits in a subcutaneous pocket, and these devices are used for 24-hour continuous cardiac monitoring for patients. And they're used primarily for arrhythmia detection in patients with subtle signs of possible abnormal or irregular heart rhythms, or for patients who've suffered from a stroke where they can't really figure out what caused it. And the greatest benefit of the cardiac loop recorder is related to the benefit in allowing them to continuously monitor patients for up to 3 years straight. And this also leads to improved compliance with monitoring over time. And so here's just an example of the loop recorder that was included in the project. It's right here in the middle. And it's called the Medtronic Reveal Link. And as you can see, it is a little bit smaller than the size of a AAA battery. And then at the very bottom is the Medtronic Reveal XT, which was the model that was created right before the Reveal Link. And the Reveal Link in the middle there is 88% smaller than that Reveal XT, which definitely aids in patients liking it better and helps reduce the cosmetic disruption of the skin too. So just to expand on the history a little bit, that Reveal XT was introduced in 2009. It was one of the first implantable loop recorders to be widely accepted and widely utilized and everything throughout. And it was really a helpful device in trying to figure out exactly how patients could be monitored on a long-term, consistent outpatient basis rather than using just external models that were previously used, usually like the external 5-lead monitors, which are kind of like the models used in hospitals now with the wires, and patients were responsible for changing those out. There were leads and patches, and they had to take them on and off for showering. So just since they were so bulky and required so much of the patient involvement with changing it, it really led to pretty inconclusive results a lot of times. Patients kind of got frustrated with wearing them, using them. They would take them off before their maximum 30-day monitoring period. And again, these external monitors were okay for a maximum of 30 days, whereas the Reveal Link is okay for up to 3 years. And actually a newer model that was just introduced is even longer than that. So the cardiac loop recorders have really gained popularity for extended cardiac monitoring compared to the external monitors, and their popularity has soared after the smaller Reveal Link was introduced. And with the advent of the Reveal Link in 2014, the devices were more discreet. They were okay to be implanted in an ambulatory setting using local anesthetic, and they were actually created by the manufacturer just essentially to be injected under the skin rather than requiring a surgical incision like the Reveal XT previously had. And once the Reveal Link was created and was more discreet and marketed to be completed in a more efficient manner, their popularity increased even more, and their expanded use has included even more indications. So now the Reveal Link is used to still cover cryptogenic stroke and vague symptoms potentially related to arrhythmias, but it also has some indications for including monitoring patients post-ablation for continuous monitoring, and its small size has actually been trialed with successful results in the pediatric populations as well. And there have been some studies evaluating, just with physician shortages, how nurse practitioners and even nurses can safely implant the devices, which saves physicians for more complex procedures, and they can be completed in an ambulatory care setting, which actually might even make them more accessible for for a broader population of people. And currently, the manufacturer of the Reveal Link Medtronic does recommend the device to be implanted by injecting local anesthetic alone for pain control with these procedures, so not a painful procedure by nature. And this device and the scholarly project focuses mostly on this last part. So rather than continuing processes involving sedation and implanting the devices in a cardiac cath lab with a surgical incision, like what was previously standard with the previous loop recorder models, now it's actually more favorable and actually recommended to implant the devices in procedure rooms without sedation and using local anesthetic alone, just infiltrated in that subcutaneous area where the pocket sits. And it just gets injected right under the skin, so no cardiac involvement as far as it actually having contact with any cardiac structures. And this is significant to nursing, healthcare providers, and advanced practice nurses for various reasons. So first, for nursing, it highlights the need to recognize maybe some stagnant processes that aren't as up to date with the times as they should be. And then for healthcare providers, it increases the ability to expand access to a more far-reaching population by allowing advanced practice providers to implant the devices. And it also reserves acute care settings and critical care settings for more urgent procedures or emergent procedures like cardiac catheterization or pacemaker implant. And then finally, for advanced practice nurses, it emphasizes the role that nurse practitioners can play in offering more diagnostic options for patients, hopefully increasing diagnosis rates and adequately offering services to patients despite a widespread and evolving physician shortage. So the purpose of the scholarly project was to evaluate the effectiveness of a quality improvement project that took place that eliminated moderate sedation from implantation of cardiac loop recorders, and it shifted the procedures out of the cardiac cath lab and into a procedure room. And the goal of this project was to promote improved patient-focused measures, decrease resource expenditure, reduce departmental costs, and eliminate the risks associated with excessive use of sedation or over-medicating for simple, minimally invasive procedures. And the project sought to answer the following research question: will the use of local anesthetic as opposed to moderate sedation in adult patients undergoing implantation of the Reveal Link insertable cardiac monitoring device lead to decreased ratings of pre-procedure anxiety, post-procedure pain, duration of procedure, equipment costs, and length of outpatient visit? And that question was guided by a literature review, which found three consistent themes of safety, resource expenditure, and efficiency. So I will talk about each of those here. So for safety, several researchers found 0% rates of infection when procedures were moved from the cath lab or electrophysiology EP lab settings to a procedure room. And several also found 100% accuracy rates in the device implantation going correctly. The device was found to be safe in a pediatric population, which I mentioned earlier, and it also had the highest satisfaction scores overall. It possesses a higher diagnostic yield for patients suffering from syncope compared to the external monitors that patients would remove early. And 100% of patients in some studies had either a very positive or positive experience when undergoing implant in a procedure room. And there was no death in any study relating to implanting the loop recorders in a procedure room with local anesthetic, which further emphasizes the importance of considering alternate options. And for resource expenditure, the research agreed that 1 to 2 nurses could be successfully utilized for each procedure rather than my facility's use, which was 3 nurses per procedure. And the research also found that it resulted in the need for less monitoring equipment because of the sedation-related risks being eliminated. And cost savings were variable, but researchers found over $1,000 might be saved with all costs considered per procedure, along with over $80,000 in cost savings annually. And researchers also focused on the importance of nurse or NP-led opportunities, reserving physicians for other duties, as I mentioned earlier. And then finally, the literature focused on efficiency, which was really a common theme across all of the studies evaluated. So out of the studies reviewed, all of the authors agreed that local anesthetic was the preferred agent, except for one, which was conducted in a pediatric population. And some studies actually demonstrated that infection rates were lower in the procedure room, with some speculation that it could possibly be related to decreased complexity. And most authors found that infection rates were low overall, between 0 to 1% at the most. And another study found that switching procedures out of the cath or EP lab meant the procedures were less likely to be delayed by over 15 minutes. And then finally, one study found there was 100% physician satisfaction and high ratings of ease of use after procedures were switched from a cath or EP lab setting and into a procedure room without the use of moderate sedation. There was also one study that found that 91% of physicians wanted to permanently move those procedures out of a hospital-based setting and into an office-based setting. And the theoretical framework for the project was rooted in Everett M. Rogers' diffusion of innovations theory, which focuses on the 5 steps of awareness of an innovation, interest in the innovation, evaluation of an innovation's effects, trial of a new innovation, and persuading adoption of the innovation into clinical practice. And within this step, there are 5 key factors that influence whether a person will adopt an innovation, and those are observability, meaning they can see how the innovation will promote improved outcomes, trialability, so they can test it out, see its effects, the complexity of it, which, as noted above in relation to this procedure, decreased complexity was related with increased satisfaction. Also, compatibility with current practices, meaning it will seamlessly fit into a working process in place, and then some sort of advantage associated with the innovation, which for this project offered hope for improved patient-focused outcomes and decreased resource expenditure. So in order to answer the research question, a quantitative retrospective chart review was performed evaluating patients who underwent loop recorder implant between March 16, 2020 and April 26, 2021. And the elimination of moderate sedation and movement of procedures out of the cath lab took place on October 4th, which allowed for 7 months pre- and post-intervention for comparison. A total of 33 patients were considered in pre- and post-intervention groups, and data was collected and analyzed using descriptive statistics and a Mann-Whitney U-test. The final sample consisted of patients meeting inclusion criteria, which I've listed here, and obviously failed to meet exclusion criteria. Patients were primarily Caucasian, between 18 and 90 years old, and consisted of both males and females. And this is just a little breakdown of the intervention itself and what was entailed with the movement of procedures out of the cath lab and into a procedure room. So as you can see, elimination of moderate sedation meant patients could arrive closer to the scheduled procedure time since they did not need IV access or labs. They had no driving restrictions after the procedure since they did not receive sedation. They didn't have to be monitored during procedure or for additional time after procedure. They were not restricted from eating or taking medications prior to arrival, which was favored by many patients. And they liked that they could drive themselves to and from procedure instead of burdening family members or friends. And then after the intervention, the department was able to just use 1 or 2 nurses instead of 3, which opened up opportunities for that 3rd nurse to help with other departmental needs. And then one other thing that I don't have listed here that I mentioned earlier is that a lot of these patients received these monitors post-stroke upon discharge from their admission. So I really like that we weren't giving them sedating medications or Versed, which can alter people neurologically. So we had very accurate neurological assessments all the way until they were discharged, and there was no question if changes were related to medications or the pathology of their stroke. And after data was collected, statistical analyses were performed using SPSS statistics to perform a Mann-Whitney U-test to assess differences in pre-procedure anxiety, post-procedure pain, and duration of procedure in the pre-intervention and post-intervention groups. And then descriptive statistics were used to compare differences in outpatient length of stay and departmental costs. And the results were statistically significant in showing reduction in pre-procedure anxiety in patients who underwent loop recorder implant according to the process change using local anesthetic alone in a procedure room. And the results are listed here. And similarly, a Mann-Whitney U-test demonstrated statistically significant results in decreased post-procedure pain with the use of local anesthetic alone, as seen here in the tables. The mean rank is decreased in the local anesthetic group, and the U score is statistically significant at 0.047, less than the significance value of 0.05. And for duration of procedure, there was also a statistically significant decrease demonstrated by a Mann-Whitney U-test, indicating that duration of procedure was significantly shorter in the post-intervention group compared to the pre-intervention group. For procedural-related costs, the average cost in the post-intervention group was approximately $87.66 cheaper than the pre-intervention group. And in 2019, which was a regular year for the department without COVID-19 restrictions, 96 loop recorders were implanted, suggesting a potential yearly cost savings of $8,415.36, and that's just by eliminating excessive resources. It only considered equipment and medication-related costs. It didn't consider personnel, additional procedures that could be completed in the cath lab simultaneously, physician hours saved, or the actual procedures that could be added to the schedule. So actual cost savings could even be higher than this number. And I thought this outcome was very interesting too. This question focused on a comparison of 14 outpatients pre-intervention and 14 patients post-intervention. The pre-intervention length of stay for outpatients was greater than 125 minutes long for almost all procedures, whereas the post-intervention length of stay was between 62 and 77 minutes long, so sometimes half the time following the intervention. So realistically, we could do almost double the amount of loop recorders in the same amount of time with elimination of moderate sedation and in a procedure room. And despite there being statistically and clinically significant reduction in the measures, there were some limitations to the study. So for one, there was a small sample size of only 66 patients, and they were almost entirely Caucasian, which limits the generalizability to the population as a whole. And the project took place at a single facility in a single Midwest region, which also might limit generalizability to the whole nation. And importantly, right after the project started, my facility restricted any non-urgent outpatient procedures from taking place due to COVID-19, which significantly reduced the number of procedures that took place. Actually, no outpatients were done for about 3 months straight due to the restrictions and the fact that the implant is not considered emergent. Some other considerations with regard to limitations include provider differences might mean some are quicker than others just naturally. They might educate their patients more thoroughly than others, which might offer them greater peace of mind, sense of security, more trust in them, etc., which could, relate to their overall perception of pain or anxiety. And then also patients' familiarity with procedures. So if a patient's already been through open heart surgery, they might think that, having a little device implanted in their skin is no big deal. Whereas someone who, is more medically naive, has never really had a whole lot of procedures, they might think it's a lot bigger deal and have, false expectations and more procedure-related anxiety. And then additionally, as hoped, all of these measures, which were discussed earlier, were actually able to be eliminated with the rollout of the process change, which allowed for better allocation of resources. It also improved safety measures and kind of decreased the hassle to the patient as well. So all of the things that we aimed to get rid of, we were able to accomplish. Some strengths in the study included that department-specific measures remained consistent throughout. So all staffing remained the same. There was no staff turnover, no physician turnover. The staffing ratios were consistent in each time period. The loop recorder itself comes prepackaged with a manufacturer toolkit, which each physician utilized consistently and did not deviate from that recommended implant process using their tools. Therefore, the physician technique or skill in affecting the results really wasn't a barrier to it because they all use the exact same tools, the exact same method for implanting the devices. There was no data missing upon data collection thanks to department-specific navigators and ease of charting appropriately. And then standardized equipment packs were used, which helped in estimating costs, as each procedure in the pre-intervention period had one standardized pack of equipment, and then in the post-intervention period, there was another standardized pack that was used, which allowed for accurate cost estimates and comparisons. And then overall, the fact the process was simplified rather than complicated or adding additional steps actually promoted nurse and physician satisfaction and adherence to the project throughout. Most people were actually really excited about the simplification, so that was definitely a strength since most changes deal with adding worker steps. The greatest barrier of this project, and probably every other project completed in the past year and a half, was the COVID-19 pandemic restrictions. So this completely eliminated outpatient procedures for 3 months, as I said, and honestly, volume and census at the hospital overall was actually significantly decreased. So this affected the volume and the number of these procedures we were doing as inpatients too, and it greatly affected the final population size. The research department also had staff furloughed, so it took a while, sometimes weeks, before receiving answers for certain facility-specific questions relating to research, which was a major delay. And then interestingly, at the end, the facility actually stopped all research that was not related to COVID-19 or Joint Commission processes. So I was lucky I had collected all of my data within the department. The secretary kept the log, but this would have been the biggest barrier faced, as I would not have been able to complete the project at all if I had not been able to have the list of patients that the secretary tracked within my department. And then facilitators, on the other hand, there were many that helped facilitate this project. So primarily Dr. Berger and all of her helpful insights, suggestions, guidance, reassurance throughout. I really can't thank her enough. The university as well, just the assistance with thoroughly helping to plan out each step of the project, so I never felt alone. And then facility-specific helpers, too, included management support of the project. They were really excited about the potential of having a more streamlined process that would be favorable for patients, physicians, and staff, and potentially decrease use of resources as well. So the facility itself is typically very welcoming and accepting of nursing research as well. They encourage research from all levels of nursing, and their IRB coordinator was very helpful until she got furloughed for some part of the project. But those things all helped. The physicians I worked with were a major facilitator of the project too. As soon as I brought the idea to them, they were very helpful. A lot of them had been involved in research previously and helped offer tips and suggestions. And they adhered consistently to the new standard process, offered their interests, their opinions, and were very helpful. They were helpful in educating their patients, so they knew exactly what to expect as well. And then overall, the implications for this project for practice include the importance of consideration of evidence-based practice and nurses at all levels, consideration of evidence and recognizing and identifying areas for improvement, utilizing current evidence to make patient-driven changes in their best interests, and the opportunity to continue to evolve with the times and incorporate evidence into daily practice. And then obviously this project focuses majorly on the potential for patient satisfaction increases due to potential expanded access to care, less reliance or dependence on others, prevention of sedative-related adverse outcomes, ease of procedure, and then actually one of our patients did his procedure on his lunch break and went right back to work, so he was really happy. So this project ultimately also stresses the importance of adaptability. By adopting innovation, there might be an opportunity for safer procedures, less cost for the facility, and offering a foundation for other less invasive procedures to be completed in alternate settings. So this simplifies the procedure, prevents the overuse of acute care facilities for less urgent matters. And a couple additional strengths that took place after the research project included the hospital adopting an even better process for implanting the devices at the bedside. So the nurses just take an equipment cart up to the room, all the equipment packs are in there, and there's no need for transporting the patients out of their room. And then this was favorable by our physicians who passed it along to other physicians, and other facilities within the healthcare system are also making changes to adopt the process and make it the new standard across the healthcare system in our region. Future research needs to be conducted with a larger sample size and without COVID-19 restrictions. The sample size, as I said, was a major limitation, and hopefully future research can be based off this study and evaluate alternate forms of analgesics to control pain, minimize procedure-related adverse outcomes, find alternates to opioids, and consider transition to office-based settings. And then in addition, longitudinal outcomes should be focused on in order to assess how patients do outside the immediate post-procedure period. So overall, the process change led to improved patient-centered outcome, reduced pre-procedure anxiety and post-procedure pain, decreased departmental costs with annual cost savings estimated over $8,000, more efficiency by reducing duration of procedure and decreasing outpatient length of visit, and promoting innovation by avoiding complacency and the habit of remaining stagnant with previous processes. So this study can serve as a foundation by which future research can base practice changes and evaluate the potential for improved patient-focused outcomes, alternate forms of pain control, expanded access to treatment, fewer restrictions, and the potential for improved patient satisfaction related to improved patient-focused measures. And at this time, I would like to offer the opportunity for any questions to be asked. And then here's a list of all of my references. Thank you.